Welcome. This presentation focuses on the issues and solutions to reducing potentially inappropriate medications in nursing homes. The presentation is brought to you by Dakota Geriatrics at the University of North Dakota, which is funded by the HRSA Geriatric Workforce Enhancement Program. Long-term care facilities have significant challenges regarding resident management. Nearly 66% of nursing home residents have cognitive impairment, and 80% of these individuals have one or more behavioral issues. It is no surprise that understaffed facilities have stressed nursing staff who have to deal with an assortment of behavioral issues ranging from violence to listlessness. Given the prevalence of abnormal behaviors in nursing homes, we might be lulled into the belief that pharmacological management is the ideal, if not a practical, solution. Unfortunately, drugs meant to modify behaviors are profoundly defective. They have unacceptable side effects that range from death to permanent damage, such as tardive dyskinesia. Other adverse events include falls, stroke, and heart attacks. Thus, we might tilt our view that safety concerns outweigh the marginal efficacy of behavioral modifying drugs. If this idea does not drive efforts to deprescribe, then other factors might help us commit to reducing unsafe medications. For example, eliminating medications can help address the staff shortage in nursing homes by decreasing time spent dispensing unsafe medications and dealing with their adverse events. This approach would complement efforts to emphasize non-pharmacological approaches to deal with behavioral problems. Finally, facilities strive to achieve 5-star CMS ratings, and reducing chemical restraints in the nursing home is a clear pathway towards this goal. Of course, like any health system problem, barriers exist. In the nursing home, administration and staff often prioritize problems other than medication reduction. They focus on proper delivery of medications per doctor orders and have no inclination to challenge the doctor. Currently, many facilities are understaffed by 10 to 15%, thus making a hard case for taking on any new initiatives. Providers are overworked and experience burnout that thwarts attention towards medication changes that need to be monitored. Furthermore, physicians often express concern that staff are underprepared to implement non-pharmacological interventions of behavior, and they are disinclined to deprescribe for fear that they may make things worse. If you understand and accept the why of deprescribing, then the method for deprescribing takes on new dimensions. For example, to reduce or eliminate unsafe medications, multiple stakeholders need to be on board. The first step in deprescribing from a health system's perspective is to document or list all residents who are taking potentially inappropriate medications. In this manner, you can track the percent of residents whom you reduce or eliminate harmful medications. As inferred earlier, research shows that only 15% of patients benefit from antipsychotics. Thus, an aspirational goal for antipsychotic reduction would be to have no more than 15% of a nursing home population be prescribed antipsychotics. Another method is to nip the problem in the bud by de-escalating antipsychotics shortly after admission to the nursing home. Oftentimes, residents were prescribed antipsychotics in the hospital due to an acute illness that precipitated delirium. Once resolved, there is no evidence that antipsychotics are beneficial. Thus, a 1 to 2 week weaning of the antipsychotic after hospitalization would be appropriate. Successful reduction in the burden of antipsychotics requires a multifaceted approach. Staff need to be educated on non-pharmacological treatment of behavioral disorders. They also need to be instructed on the cyclical nature of behavioral disorders. Furthermore, they need to consider unexpressed pain as a driving force for behavioral issues in demented patients. Once staff have the knowledge and skills to manage behavioral disorders through distractions and other techniques, they need to be educated on how to report behavioral problems to physicians. That includes SPAR recommendations such as short-term rather than ongoing medication interventions. Beyond staff education, facility medical directors and QAPI directors need to plan quality improvement projects for the purpose of reducing the facility's antipsychotic burden, both in terms of dose reduction and drug elimination. These quality improvement goals are best driven by interprofessional approaches. Finally, patient advocates such as their family members or powers of attorney can be highly influential in this process if they are properly educated about the pros and cons of antipsychotics. Here's a list of questions that can help prepare a nursing home to tackle the difficult issue of antipsychotic deprescription. Firstly, each facility needs to know which of their residents are prescribed antipsychotics and the reason behind the prescription. Ultimately, the rationale behind an antipsychotic prescription needs to be challenged or justified, thus setting the foundation for using antipsychotics in a manner other than chemical sedation. To understand the impact of deprescribing, data needs to be generated from behavioral scales such as the Neuropsychiatry Inventory Index, or NPI, in order to see if our efforts are bearing fruit. To summarize our thoughts about antipsychotic reduction in nursing homes, we need to firstly acknowledge the fact that psychotropic meds can be harmful. Once we get stakeholder consensus about the need to trim the sails on antipsychotic use, we then need to establish a registry or list of residents who may be on inappropriate medications. Through this list, healthcare providers and staff can evaluate the impact of reducing the dosage or elimination of antipsychotic medications. Efforts to reduce unsafe medications in the nursing home should naturally be part of QAPI. Remember, small changes in the healthcare setting require data in order to adopt or reject plan, do, study, act cycles of change. Thank you for your attention today. If you wish additional information, please contact Dakota Geriatrics, a HRSA-funded geriatric workforce enhancement program.